Hey everybody, so here is the video for Study Guide 3. We go over, I think, 4 cases here. And if you've already, hopefully you've already looked at Study Guide 3 and gone through it, but Study Guide 3 concerns the brainstem, the spinal cord, spinal roots, and so we'll go through a few cases highlighting some of that stuff. And here is our first case. We have a 37-year-old woman who is in her 3rd trimester of pregnancy, doing well from that standpoint. She wakes up one morning looking like this. Her neurologic exam is otherwise normal. So sometimes when you see something like this, it takes you a moment to figure out what's normal, right? Which is the normal side. But if you look carefully, you can see she's got evidence of muscle contraction all throughout here on the left. We don't really see it so much up in her forehead, but down here you can see she's contracting muscles. There's nothing over on the right side. And her eye is more open on the right. That tells me that she just can't completely close that eye or scrunch it up like she can the left eye. People often, when they get a Bell's palsy, which is what she has, will talk about how the right side of their face, or the affected side of their face, is kind of tingly, in her case, the right side. But there really should be no sensory loss, right? Because the sensation, at least to touch, is going to be from the trigeminal nerve. There can be some changes to taste depending on where along the course of the nerve the injury happened to the anterior part of the tongue. Okay, so you remember how the face is wired, right? So back in Foundations, I know you studied this, but the top part of the face up here is bilaterally innervated. So if you have something like a stroke, it's not really going to affect the upper part of the face. And I should say a stroke in the brain. It's not really going to affect the upper part of the face. But if you have a stroke in the brain, you can get weakness of the lower part of the face, and it's contralateral, and that is because the lower part of the face is innervated unilaterally and contralaterally. So I have a right brain stroke. I'm going to have weakness of the right lower face. Okay, it's pretty simple, but my forehead is spared. When you have a peripheral lesion, which is a lesion in the nerve itself, both the upper part and the lower part of the face are weak. I threw in the House-Brackmann, really not for you to memorize. Please do not memorize it, but because sometimes it comes up. Sometimes you may encounter it. Sometimes people use it when dealing with things like traumatic facial nerve injuries at Harborview, or with vestibular schwannoma resections and facial nerve injury. Okay, so Bell's palsy. You will hear people, a lot of people use Bell's palsy synonymously with facial nerve palsy. To me, Bell's palsy means that there's a viral etiology. Whereas a facial nerve injury itself could be from a viral illness or trauma, a tumor, whatnot. So when I say Bell's palsy, I mean the kind that's associated with viral illnesses, etc. There is a heightened risk in pregnancy, which is why I made our patient pregnant, also to try to keep the OB-GYN patient or students awake there. And then so things that you might want to consider with a Bell's palsy, right? Could it just be a Bell's palsy? Odds are, yeah, if your patient looks pretty good otherwise, but you wouldn't want to miss one of the more worrisome possibilities. And so you're going to do a careful neuroexam, and you want to rule out a tumor of the cerebellopontine angle. So maybe you've seen those already, but tumors that lie kind of between the pons and the cerebellum and can affect the 7th nerve, can affect the 8th nerve, can affect the 6th nerve, and can affect the peduncle to the cerebellum, if not the cerebellum itself. You also want to make sure you're not missing a pontine stroke. So a stroke in the pons, you would expect more than just facial weakness. You might have a lower motor neuron facial weakness and a contralateral hemiparesis. I think we talked about that before. So, you know, if you have a hemiparesis, you're not dealing with just a Bell's palsy. Trauma, again, certain kinds of trauma, like a temporal bone fracture or whatnot, can affect the 7th nerve. And then there are systemic diseases, things like neurosarcoidosis and so forth, that can also affect the nerve and sometimes give you, in fact, a bilateral facial nerve palsy. So we've got our patient. We're pretty satisfied. I'm not going to do a CT scan on her as long as she looks good otherwise and her neurologic exam looks good. And nothing from her presentation concerns me that there's anything more going on. I'm just going to treat her for a Bell's palsy. So how are we going to treat her? So get your pen, get your paper. You got the little pause icon there, and jot down a proposed treatment and then come back. Okay, so this is what I'm going to do. I didn't really give you exact doses, but prednisone taper, so like 7 to 10 days of prednisone. Steroids, basically. Steroids is the main thing, the key thing here for a Bell's palsy. We also still typically give antivirals like valacyclovir, even though there's not really great data for them. They're pretty benign, and so we usually give the two together, but there's more support for the steroids than for the antivirals. And then, so the thing is, this is not our patient, of course. Her weakness is on the left side of the face, but she's showing us something that can happen when you have a bad facial nerve palsy. So when you can't close the eye, you can't close it at night. You may, depending on where along the pathway of the nerve the lesion is, you may not be able to form tears because the innervation to the lacrimal gland might be affected. And you can get a very bad eye injury from that, an exposure keratitis. And so when I see somebody who has a facial nerve palsy and they can't completely close the eye, I teach them how to close the eye, cover it with gauze, keep lubricant and so forth in it to protect it, both when they're asleep and when they're awake. And if the palsy is really bad and the patient really can't close the eye at all, I would refer them to ophthalmology as well. Hopefully over time the nerve function will improve and the patient will again be able to close their eye, but there are cases where patients just never really regain that ability. For whatever reason, and need to be referred to have a gold weight or whatnot put in the eyelid to help them close their eye. And then a close follow-up plan. These are people you don't want to lose sight of. You want to make sure things are getting better. Oop. Okay, but what if? So our patient had no hearing loss, but what if she had the right-sided facial weakness and she also had a right-sided hearing loss? What would you think? And the hint is it's a sensory neural hearing loss. So I already gave you cerebellopontine angle tumor. So what other things can you think of that could give you a right-sided facial nerve palsy and a hearing loss, a sensory neural hearing loss on the same side? So get your pen, get your paper, jot down a differential of at least 3. And again, I already gave you a tumor, and then come back. Okay, so tumor of the cerebellopontine angle. So a lot of times we think of vestibular schwannomas, but lots of things can grow there, including meningiomas and so forth. And again, that's why you're going to check carefully your abducens function on exam, and you're going to check cerebellar function on exam as well to make sure you're not missing anything. And if there's any indication, of course, that one or the other is off, you're just going to image. And in fact, if you have a patient with facial nerve palsy and hearing loss, you're going to image anyway. That's enough to know you need to image. Okay, what about Ramsay-Hunt syndrome? Remember that? So you're going to want to look carefully for rash like this. It can affect both the 8th nerve and the 7th nerve. Again, stroke in the pons, and again, you would expect some weakness or something else there, but you never know. So you want to be careful. Just be careful with your exam and make sure you're not missing anything. Okay, so here's a question for you. So what condition is strongly associated with the presence of vestibular schwannoma, and in particular bilateral vestibular schwannomas? So get your pen, paper, give me a guess, and come back. So maybe you said neurofibromatosis type 2. So here you go. You can see here how the vestibular nerve, vestibulocochlear nerve, and the facial nerve, they just all travel right there together. And so you get a tumor like the schwannoma here, and it can affect both nerves at once. And then when you get these bilateral vestibular schwannomas like this, that is very extremely suspicious for neurofibromatosis. You see this, you think that person must have neurofibromatosis type 2. Okay, so here we go, another case. So we've got a 74-year-old man. He had a TEVAR 3 hours prior. So TEVAR is a endovascular thoracic aortic repair. So basically an endovascular repair of an aortic aneurysm. And it went well, procedure went well. He's recuperating in the SICU, and suddenly he can't move or feel his legs. So you go to examine him. Mental status, cranial nerves are fine, arms fine, sensation. So here's where it starts to get weird. So in his lower abdomen, he has a sensory level. So above, everything feels just normal, but below that level, he can feel touch, but he doesn't feel pinprick and he doesn't feel temperature sense. Nor does he feel pinprick or temperature sense in his perineum or in his buttocks. His reflexes are fine in the uppers, no reflexes in his knees and ankles, and his Babinski response is negative bilaterally. Otherwise, not really pertinent neuro exam aside from the fact that you check for a bulbocavernosus reflex, and that is negative. And so you go on to check rectal tone, and there is zero tone there, zero strength in his ability to contract down there. So where does this localize? Be as specific as you can here based on this. Where is his problem? Where in his nervous system is his problem? Okay, so spinal cord, right? He's got a spinal level. His level is down in the lower thoracic region, so that's going to be my guess, somewhere maybe down in here. Who knows exactly where? We don't know where he stops feeling things. So the question is, if he's got a spinal lesion down here, how come he can feel it when you move and you touch his legs and feet? So I didn't tell you, but when you get the tuning fork out, because of course you're going to have a tuning fork, right? Of course, you took this class. So let's say you get the tuning fork out and put it on his toes and he feels the vibration for 10 seconds. That's pretty good. So then you check his proprioception, you move his toe up and down, and he feels that too. So why would he have preserved vibration and joint position sense in his lower extremities? So if you can make sense of this, jot down some ideas and then come back. Yeah, so he has anterior spinal artery syndrome. So this can complicate aortic aneurysms and aortic repairs. And so the bulk of the blood supply to the spinal cord comes from the anterior spinal artery up here. You can see its distribution on the side here. And in the back, you get some supplemental blood supply from these posterior spinal arteries. And so when you stroke out your anterior spinal artery, you can lose quite a bit of territory there bilaterally, right? But with sparing potentially of the posterior columns, so sparing of joint position and vibratory sense. What our patient has done is essentially stroked out the majority of his spinal cord and spared his posterior columns. Oh, and you can see here the corticospinal tract, which is voluntary movement, has been knocked out. Spinothalamic tract, knocked out. Okay, so here's his MRI, and you can see there's some patchy areas of abnormal signal owing to the ischemia, and this is consistent with an infarct. Busy slide. We'll skip this. Okay, so here's a question for you. So when we first went to examine him, you remember we checked his reflexes, and he didn't have reflexes in his knees and his ankles. And so, okay, and he also didn't have a Babinski on exam. But I'm telling you that he had a stroke in his spinal cord, which is considered upper motor neuron. So the question is, why doesn't he have hyperreflexia? Why doesn't he have a positive Babinski if he had a stroke in his spinal cord? Because look here, the spinal cord ends, around here. He's got stroke in his actual spinal cord itself. So that's considered upper motor neuron. So if you have a guess to that, write down your answer, think about it for a minute, and then come back. Okay, so the reason is because it can take some time for hyperreflexia and pathologic reflexes like the Babinski to be apparent. And so he doesn't have those now, but over time he will have hyperreflexia. He'll have positive Babinski bilaterally. It just takes a little time. Okay, so we talked about how the anterior spinal artery supplies the anterior cord, and when you have anterior spinal artery syndrome, that spares the posterior columns because you've got that nice little posterior blood supply there to protect them. So we know that here you get your posterior columns spared. Can you think of at least one disease that targets the posterior columns? So think about that and come back. So yeah, of course we can. So vitamin B12 deficiency can do that, neurosyphilis can do that, multiple sclerosis can do that, lots of things can do that. And here's an image of a patient with posterior spinal injury, posterior column injury. Okay, we're whipping through these. We're going to be done pretty soon. Third case is back pain. So we've got a 64-year-old man. He's diabetic. Ooh, not very good control. He has an A1C of 10. He's hypertensive. He's a pretty heavy drinker, but doesn't smoke. And he comes to urgent care because he's been having increase in his usual back pain. So he's kind of got some chronic wear and tear back pain, but it's been worse the past week or so. And he says he feels really weak all over. He just feels terrible, and he's sweating and soaking the sheets at night. So you take a look at him, and he's diaphoretic, so this isn't looking good. You palpate his back, and he almost jumps off the exam table when you get down to his lower thoracic spine, where he's got point tenderness, quite tender. So here you go. Pause your video. Give me a differential diagnosis, at least 3 things if you can, and then come up with a workup plan to pretend you're in urgent care and what you're going to do. Think about what you're going to do with him. Okay, and then come back. Okay, here's my differential diagnosis and workup plan. So epidural abscess is pretty high on my list of possibilities there. He sounds like he's sick. And it sounds like it's kind of been brewing for at least a week, but he sounds like he could be infected. He's got sweats, he's got malaise, he's at risk, right? He's got some relative immunocompromise with his diabetes and his alcohol use. Osteomyelitis, that's also a possibility, and of course the two can occur together. Could he have a pathological fracture? And the reason I think of that is because he almost jumped off the exam table when we tapped on his back. So maybe he's got a met there, or maybe, who knows, osteoporosis. And then maybe we should think outside the box. What if he's got shingles? He doesn't quite have the vesicles yet, but he's got some tenderness there. So lots of things. You want to get a good look at him. So you're going to do a good neuro exam. And that's probably the most important test that you're going to do. But you're going to do your exam, and you're going to, assuming that you can't figure it out in a pretty easy way, such as shingles, what you're going to do is you're going to order up some imaging of his spine. And if you can, I would make it an MRI of his spine with and without contrast. And I think I would go big on what I imaged in his spine. I probably would image his whole spine, his whole spinal cord. And the reason is because you don't really know what you're dealing with. And some of these things can track up and can track down. So other people would argue you can just probably get away with ordering the thoracic and lumbar spine, but we're going to do it all. We're going to get basic labs. We're going to get blood cultures, because remember, we're worried about infection. And sometimes when you're dealing with something like an epidural abscess or osteomyelitis, the blood cultures can give you the answer pretty quickly. And then what we're also going to check is ESR and CRP, because as you know, probably know, we use those labs for tracking purposes and to look for evidence of inflammation. All right, and then you anticipate that you're going to be referring him to a spine specialist pending these findings. So you're going to be a good consultant, right? You're going to follow the principles that you laid out for yourself in the consulting exercise, and you're going to actually kind of come up with a bit of a differential. You know, you're going to do a good workup, and then you're going to call and give your presentation to the specialist. Well, it turns out he's got an epidural abscess. So here's his MRI. He's got a spinal epidural abscess. And that's a surgical consult there, a rather urgent surgical consult as well. You can see how it's compressing the cord on the way down. So teaching points, high morbidity, mortality. A lot of survivors go on to have neurodeficits. Our patient now doesn't have any neurodeficits, but that could change pretty quickly, couldn't it? So sometimes these symptoms are patients who present with back pain. That's a tough symptom to know what to do with, and so sometimes these epidural abscesses can smolder on for a long time before we really pick up on what's going on. Okay, yeah, that's it. Oh, most common bugs for epidural abscess are MRSA and MSSA, basically staph. All right, I don't know. This picture I think I just put in here because I like this picture so much. We're talking about the spinal cord now, and I just like this picture because it shows you all of the things that can happen to us in our spinal columns as we age. So, you can get osteophytes, these osteophyte complexes. You can get the ossification of the ligaments, wear and tear changes. And so you can see how easy it would be to end up with compression of your cord. And that's pertinent to some of the diseases we're studying in this block, things like central cord syndrome and so forth. Here's a patient, I'm sure you guys have seen some spinal imaging by this point, but here's a patient who has probably kind of a congenital narrow spinal canal and has some of this stuff going on. And you can see at these levels, what C2, C3, C4, C5, C6, you can see where the cord itself is compressed and there's some abnormal signal of the cord indicating that the cord's having either edema or damage. And then further down, everything looks good. You get a nice CSF signal around the cord like you'd like to see, but this just looks terrible. All right, and then I mentioned central cord syndrome, but central cord syndrome, which I think you guys can study about on your own. If you don't see it, you may see it this month, but if you don't, just be sure you study about it on your own. But sometimes, this can happen in a whiplash or hyperextension kind of a injury, and you can see how all of those structures that we pointed out before can impact the cord, and then you get some bleeding and bruising of the cord, and that compresses things even more. Central cord syndrome, yes. So this is just to point out something that we've gone over before, I think when we talked about syrinx a while back, but the organization of the corticospinal tract and the spinothalamic tract and the corticospinal tract is that the cervical fibers are on the more medial surface. So if you have a process that's affecting the central spinal cord, like a syrinx or central cord syndrome, the arms are going to be predominantly affected. And so that's why patients with central cord syndrome can't really move their arms as well as their legs. They have weakness in their hands. They may have intense pain in their shoulders, their arms, their neck. And we already talked way back when about patients with syrinx who can have that cape-like distribution of dysesthesias. All right, so yeah, and we've already talked about two of these central cord syndromes now already. We talked just now about central cord syndrome. We talked before about anterior cord syndrome. You can refresh your memory on Brown-Séquard syndrome. Rare, but happens. Can happen due to things like tumors as well as stabbings, other kinds of trauma. Lumbar stenosis, make sure that you review lumbar stenosis. And again, I'm sure you're seeing lumbar stenosis this month, but this is just a reminder of why patients may get some relief if they bend forward. I think they call that shopping cart sign. But when you're bending forward, it opens up the spaces back here and it can alleviate some of the compression of the lower cord and the roots. All right, so this is the last case. We have now a 60-year-old man. He's diabetic. His numbers are a little bit better than our last patient, but he's got some room for improvement there with an A1C of 8%. He wakes up unable to raise his right foot, so he can't dorsiflex his foot. Remember dorsiflexion, plantar flexion. He can plantar flex, can't dorsiflex. And it's numb. The foot's numb, the calf's numb. So differential diagnosis, could it be a herniated disc, L5 in particular? because L5 is a muscle very important for dorsiflexion, tibialis anterior. L5, key sensation, key root for sensation in the foot and the calf. So could he have had an L5 slipped disc somehow? Well, we'd want to ask about things like back pain and, to palpate back there to see if there's anything painful going on back there. Check for radicular signs. Do your straight leg raise and see if he gets any symptoms in the ipsilateral leg or the contralateral leg. And if there were any concerns for that, we would image him. And we'd also want to ask, while we're asking about these symptoms, we'd also want to make sure there weren't more widespread symptoms, right? Ask about bowel and bladder and everything. Okay, so how about common peroneal neuropathy? What about that? So he's got some risk factors. He's diabetic, and he's not in great control, so he certainly could be at risk for that. Other risk factors you may remember for these, some of these entrapment neuropathies and for common peroneal neuropathy in particular, so illness, bed rest, when you're not moving around a lot at all. Leg crossing is specifically a risk factor for common peroneal neuropathy, and we'll see why in a moment. Could it be a common peroneal neuropathy? Well, we'd have to check, his exam carefully and see if it is consistent with that kind of a distribution, but seems reasonable, especially if we're not getting a sense of a lot of back pain or radicular findings up here. And then finally, what about stroke? Could stroke do this? Yeah, stroke could absolutely make it so he can't lift up his foot. But we'd want to check for some other things too on exam, and we'd want to make sure it was just foot and not, the whole leg. But certainly, yeah, we would want to make sure that we ruled that out as well. So we're going to do a little bit more examination here first. So we're going to check inversion and eversion. You guys remember inversion and eversion of the foot? So our patient's eversion is weak. He can't really do this, but his inversion is good on that leg, on that foot. He can invert it. He can invert both feet. So that is innervated by the muscle is the tibialis posterior, and it is supplied by the tibial nerve, not the common peroneal nerve, but the tibial nerve. And look at the roots that are affected, L4 and L5. So this tells me that if he can invert his foot, he probably doesn't have an L5 radiculopathy, because L5 seems to be working pretty good here, at least for this nerve here. And then the other reason I think this could be a common peroneal neuropathy is because it just so happens this muscle is supplied by a different nerve. So basically, sometimes people will pick on you and ask you questions about foot drop and whether it's an L5 radiculopathy or a common peroneal nerve injury. And basically, if you find that your patient can invert the foot, but they can't evert, they can't dorsiflex, it's probably a common peroneal neuropathy. Okay, and then the last thing I'll say is, if you have a patient with bilateral foot weakness, where does that localize? Well, it could localize to the nerve. That'd be a little weird, but it certainly could, especially if it was due to something like prolonged bed rest. Could be something like ALS, so you want to make sure you do a good exam to look for any evidence of anything like that. Certain myopathies could do that, yeah, or spinal cord, of course. We talk about how if you have weakness in both legs, you kind of wonder about the lower spinal cord. But basically, you're going to do a good exam and you're going to make sure that the only thing that you see going on is with the feet. Okay, that is it for this study guide, and I hope that you are all doing well with everything and hope these are not too tiresome. I feel bad that you have to listen to me every week, but I hope that it helps to go through the material to help make it stick. And I will see you for the next video.